Hello, everyone. We're going to get started in 1 minute. I did just turn on the recording. We're really happy to see you this morning. It's July 13th, and there's a lot of information about COVID and the resurgence that we will get to in just one moment. Please remember that we are recording this for the public. So if you do not want to be on the public recording, you can go ahead and turn off your video. We ask that people use the chat function to send us questions. And today, we're really going to focus on COVID and resurgence. And Dr. Dale Reisner, who is a WASHA board member and also medical director at Swedish Health Services for OB/GYN Quality and Safety, will actually be our speaker today. You might have been wondering why we've taken a break, and the point is we want to be bringing you relevant, valuable, up-to-the-minute information, and we felt like we had been doing that with our weekly calls. So we took a little bit of break, but gosh, there's a lot to talk about. So Dale Reisner will be talking about three specific overarching themes today. One is the national news and how to make sense of all the statistics. Two, she'll be talking about the science. So things like droplets versus aerosols, viral load, testing versus screening, and vaccine updates. And then we'll go ahead and talk about what you can do to keep safe. There's still a lot of emerging information on everything from masking to who should get tested. So we have a lot to talk about today, but this community conversation, which is sponsored by the Washington State Health Advocacy Association, is designed to help answer your questions. So go ahead and put questions in the chat function, and I will be asking Dale about those. If you would like to participate in asking a question, you can also raise your hand. So with that, I would like to turn it over to Dr. Dale Reisner. Thanks, Dale.
Hi, good morning, everybody. I'm going to talk about a lot of stuff that may not be that new, and try to do some clarification, I guess, would be the goal of this meeting. How do we protect ourselves? How do we protect our loved ones? How do we go about working and playing in a safe way, because COVID's not going away. So that's the intent. I'm going to try to leave lots of time for questions and answers. And then I even have a little surprise for Robin. She doesn't know what I'm going to do. She usually knows what I'm going to do.
Uh-oh.
Now. So, okay. Yeah. So I'll start with the way I often start with just statistics. And we know that a lot of the attendees are here from Washington State, and we're the Washington State Health Care Advocacy Association. And so we'll talk about that, but I think we have to be looking at the entire country. And so you may know, if you're paying attention on a frequent basis, and I'm not necessarily encouraging you to do that, but you may know that we hit over 60,000 new cases in one day over the last couple of days. And that's across the country. We have over 137,000 deaths in the United States. So it's taken a huge toll. We're not done yet. It's a novel virus, so none of us were exposed to it in the past. It is related to the common cold and related to SARS and MERS, both in the COVID viral category. So this is COVID-2. But it's not the same, and it's got a different infectious risk. It has a different mortality rate, probably, and certainly, you know, compared to common cold, which is the most common coronavirus that's out. We don't know the actual mortality rate. We won't know the actual mortality rate even for a new virus, until we have universal testing available. And I don't know when we're going to even have that. So we have guesstimates that it probably has a mortality rate close to 1% for most of the general population, clearly much higher as you get older, particularly in the 70s and above 80. So, that's a good thing to know, but no one's protected. So we've seen, recent occasional death reported of a child. We've seen some other complicated cases that have come from children developing secondary issues with their hearts not working properly. And so this virus actually has a very wide range of effects on people at different ages and with different immune systems and different comorbidities or, background medical conditions as well as age.
And I just want to point out, we do have people hailing from across the country, Florida, California. So welcome to all of our advocates and others who are joining us from other parts of the country. And they're kind of curious about how Washington, California, Florida, how the different states are opening up, that kind of thing, which we'll get to. But
we can talk about that towards the end. I think that's really helpful, and I just say I'm so sorry if you're from one of the states that's having such a huge uptick right now in cases. So if you look at the states, there's a handful of states, about 5 states, that have the highest volume of cases right now. Florida's one of them. Texas, Arkansas, Arizona, the part of New Mexico had a big increase. Within Washington state, we, not fresh, but in the last month, had a big increase in the middle part of our state in Yakima County and Benton County, which are very rural, and a lot of farm workers that have been infected. So even if your urban areas in your state get hit initially, it can take a while to percolate out into the countryside. It will get there eventually. There are some states that seem to be very low numbers and have consistently stayed low numbers. Alaska's one. It's very far away from everybody else, but they did have people that travel in and out quite a bit. And there's some of the states in the Midwest that have been quite protected so far, and some others that have been hit really hard. So just know that we are going to all be susceptible until there's a vaccine, and we'll talk about that in a little bit. In Arkansas, in Lee County, when looking at counties across the whole country, Lee County has the highest number of cases of any county in the U.S., and they had 1 out of every 17 residents that are positive. So hopefully you're not living in Lee County. If so, you need to be extra careful. And we're mostly going to focus on protection with this conversation. But it just speaks to it doesn't matter where you are. We have this virus that's in our country, and we have to pay attention to it.
And
yeah.
So Michael Wood, who's one of our board members, just asked this question. I thought it was really good. Can you summarize the instance of serious short and long-term effects of COVID? Just trying to make sense out of these statistics, because the death rates appear to be going down, but are they covering up some of the other bad effects?
Right. So we don't really know that. There is some data out of the United Kingdom, but I don't know how applicable it's going to be to the US. There's a different population there, and it might even be a different viral mutation that's there. But we do know that the majority of the complications and the risks are short-term, and that the sicker you are, the greater your chance of either mortality So if you're hospitalized, if you're so sick that you're hospitalized, your mortality rate is higher. And if you're hospitalized and need to go into an ICU, intensive care unit, or need to be ventilated, your risks are quite high. So before we had some clear options for therapy that work, when there was a lot of voodoo around, with people trying things that they thought might work. Understandably, when we get scared, we want to try things. And if you were placed on a ventilator, you had, depending on your age, you had at least a 50% chance of dying.
Wow.
So even with a younger person, and the older you were, the greater. Like if you were in your 80s, it was about a 90% chance of not recovering. So, you know, having the majority, the problem is we don't know who has had really mild symptoms, like if they thought they had a cold, or they thought they were having an allergic response to spring, because we haven't been able to test everybody. So I think when the dust settles in the countries that have had better testing than in the US, probably never in the US, we're going to have a much better sense of what percentage really is asymptomatic, what percentage is mildly symptomatic. And, you know, the majority of folks that are spreading are going to be the sicker ones because they are more likely to be coughing and those kinds of things.
Somebody also asked, the county that you said had the 1 out of 17, that was Lee County?
Lee County in Arkansas.
Arkansas. Okay, thank you.
Yeah. So, you know, it's not a place in Florida, even though Florida has a huge upsurge in cases. In Washington State, we are running now a little over 39,000 positive cases with 4,600 plus people who have been hospitalized for coronavirus 19. And within that group, 1,424 deaths. So that was as of yesterday. That is about 3.6% of known cases. But as I was saying, if you, depending on how you look at it, if it's an older population, the death rate is definitely a higher percentage. And we don't know how many people are asymptomatic. So the overall death rate, I think, is going to be hard to predict. We've had over 650,000 tests done in Washington State, and it's pretty consistently between 5 and 6% that are positive. So it's not that everybody is positive, but the problem again is that we're mostly testing people that are in high-risk populations, high risk from work, or that are sick. So even at that, the positive rate is pretty low considering the number of tested people. The concern about that is that you get a little cavalier about the majority of people you're hanging out with probably aren't infected. They don't have symptoms and, you know, they haven't been tested, but you're in the incidence in the population may not be as high as it was or that we think it is. And again, it's a little bit of a conundrum because we don't have complete testing. And I'm going to talk about testing in a little bit about why we shouldn't have the ability to test everybody right this second. So if you have a question about that, I am going to address that. So any other immediate questions before I'm kind of moving?
Well, we do have a question, and I don't know if anybody's on to answer this, but and there is actually Tina Hall, who is just coming online. Welcome, Tina. There's a question that you might be able to contribute to right away. So welcome. So Melissa Cardine from Arizona said one of her concerns is that patients who are in assisted living communities who are testing COVID positive and the hospitals won't keep them with crisis standards of care in place in Arizona. So if they have a do not resuscitate, they don't want to keep them in the hospital and they send them back to assisted living. Yet assisted living is not equipped for skilled care, which most of the elderly patients who are battling COVID need a higher level of care. So they put them on hospice, and she believes that they could be battling COVID if they had the resources to recover. So, so she was curious as to what's happening in Washington State, and I might just call on Tina Hall if Tina's able to comment on that.
Oh. Hi, this is Tina. That is a
I know that question came right in, and
Right.
just kind of hopping in.
And if you don't have an answer,
let me think about it a little bit as we continue. Let me come back to that if you don't mind, just because I know that is something we are grappling with in all communities, is how do we handle that if someone goes out. I'm probably less in a position to speak to it than some, because at present we have not had to deal with a lot of that because of some of the other things we've done within our communities. But I know that is something that as an industry we are struggling with. How do we safely take someone back into our community and not risk exposing the rest of our residents when someone does come back? I know that at some point in the last few months, we have had a situation where this has happened in one of our communities. And of course, in a situation like that, we are taking people in and doing full isolation, full on PPE with the drop cloth protection, only one caregiver, as many isolation steps as can possibly be taken to keep people safe. But I can only speak to what we've done a couple of months ago, since we haven't had to deal with it most recently.
Right.
Yep. Thanks for jumping in, Dale.
So I will add that fortunately, we were prepared for it. We were never in crisis mode in terms of what care we offered in Washington State. We expanded our ability to care for people in the hospital as much as possible. So we were able to keep some of the sick but not ICU type patients in the hospital on COVID cohorted units. We created a COVID cohort unit and still have some beds for OB patients as well, because we're getting a few patients that are asymptomatic and positive in the women that we're testing just prior to scheduled procedures in the Swedish system. So we lucked out, I would say. I think we were prepared. We jumped on it. We've done a really nice job in our state of being not overly aggressive to begin with, but jumping in pretty quickly when we saw we needed to. And I think all of the hospitals have been communicating with each other and supporting each other. Yakima, for instance, has not had enough beds, and they sent some people to Spokane and to Central Washington and to the Seattle area actually as well. So lots of places willing to take sick patients, and some of those clearly are nursing home patients as well. Let me move on, and then we can come back to that question, because I think it's really important to address that. And part of what I'm going to talk about with spread will address the precautions that it sounds like you've already taken, Tina, that actually should be sufficient. So I wanted to do something a little bit different. Most of you guys probably know the name Alda. I did not realize that he's been, for the last 10 years, doing some interviews with different scientists. He's been very into how we can spread fact. And he has been advocating for better communication around what is true versus what has been published. And in science, just like with many other things, sometimes things get published that aren't applicable to everybody, or that aren't entirely accurate. And so you have to look at sources. So I want to read his quote because I think it's super cool and something that anyone could apply. He said, one of the most basic things I've tried to do is give people a greater understanding of how science works. The importance of evidence, the importance of many trials, not just one, of rigorous studies, and the idea that we learn only a little bit at a time. And this is so applicable to COVID. We are learning a little bit at a time. No single study is the end-all answer for everything, for anything. And I added the for anything at the end because that's so true. And you can see a study that's done with a large population, but that large population doesn't match yours. And so it's not what we call generalizable to the world. So you have to be really, really careful, and you need to look at if they've got too many subgroups, or, you know, that they've age adjusted, or if they've adjusted for having comorbidities, those kinds of things when you're looking at the literature. And it speaks to where we're at with COVID, because we've had, in an attempt to get any information, we've had a lot of not super well vetted articles published, and it's created some chaos. So just understand that's well-meaning, but that it makes it hard to interpret what's real and where we go moving ahead. So I just wanted to start with that. And already mentioned, you know, older people and people with other medical conditions are our highest risk population. So that population, whenever possible, needs to stay away from other people. If they are in a family situation and their families are close by, their families need to be extra cautious when they go out someplace and come back in. And that's the population we still need to be super careful of.
And by extra cautious, you mean paying attention to hand washing and masking and.
Yes, yes. Mm-hmm. And I can't, and it's perfect, Robin, because I cannot overemphasize the hand washing enough, I think. So the spread is really, you know, been a lot of stuff published about how this virus is spread. It's not a living organism, it's viral particles, and they get into your system through mucous membranes. So that's your eyes, your nose, your mouth. And it comes mostly from these things here. And so if we don't take care, I see Annie's got her hand right here, right?
What is that?
Do it too, right? Who doesn't put their hands? I adjust my glasses, I adjust my eyes with my allergies. It's such a huge retraining for us to keep our hands clean and away from our places where we can get it. I'm not going to get it off my arm unless, you know, there's fresh virus there and I rub it on my face. So it speaks to the concerns people have when they're walking outside, if they're exercising outside. Inside is where we see our biggest spread. And an example I'd like to, you know, we talk about droplets versus aerosol. There's aerosolization and there's aerosol. So that has to do with how small the particles are. And yes, the information that you're hearing about now about how singing you may have aerosolized your, or you may have aerosol particles. Those particles are not the same as if I undergo an intubation, deep process where oxygen is spewing with force my virus into the room. So it's different. It's still a risk, but standard masking, gloves, eye protection for those of us that are healthcare providers. And you see people in the stores now, some of them with a mask that's clear. That's actually the best protection you can do, because I could potentially get, you know, something in through the side of my glasses. So those things super important for if you're working in a place where there's patients or family members that are positive. Or if you're in an area where there are a lot of people that are declining to wear masks. So we'll talk about that a little bit. Human to human is the way we spread this disease in the most effective way. It's not the most infectious virus that we know of, but it's more infectious than the flu, not quite as bad as the measles. And so it's one of those viruses that's easy to pick up if you're not careful. The question about surfaces, the virus can be detected off surfaces, but as I said, it's not a living organism. So again, that would require fresh virus particles on my hands or somewhere, if I put my hands to my mouth, that would have to be pretty current in order for me to get it that way. Again, when we look at case finding, most of what we're determining is that it's person-to-person contact.
So we do have a question. I just wanted to pop in here from Ray Drazen. Isn't it true that if you wear a face shield, you should still wear a mask unless you can't wear a mask for medical reasons?
The face shield gives a gap, and that's what I'm going to talk about it next. Is really what does masking do? So if I wear a mask, I am protecting you if I happen to have the virus or anything else, but don't have symptoms. And ideally, if I have symptoms, I'm not out there running around. But if I'm wearing that mask, I'm protecting you. If you're wearing a mask, I'm protected from you. So that's why everybody masking works. If some of us mask, so when I'm in the grocery store and there's somebody who's not masking, I turn and walk the other way. And I'm still protected from my mask to a certain degree, but it's the other person's mask that's going to protect me more than my own mask.
So yes, and. So yes, and. So there's different levels of, we haven't really talked about the masks with the filters versus different materials and 3 layers and 2 layers. And can you comment on that?
The cloth mask is really good for protecting us. And if you want to add extra, number of those are being made now with a little spot for a filter. So I just happen to have some masks with me today, Rob.
Oh, I love it.
I'm going to clean my hands. I'm not going to, because then they'll still be wet. But before I do anything, my hands are clean. So soap and water actually works the best because it's abrasive, right? Mm-hmm. If you don't have that, like I always have this in my car. Or a spray. And so my hands are clean, and I have a mask here that I picked up in the store. It's cool. It's almost like a surgeon's mask. And most of these masks will prevent particles of 2.5 millimeters from microns from getting into your face. So that is a little less, minimally less than a surgical mask, and a little bit less than an N95 mask. So I got these masks, and I want to show you this. This is a little bit grade school, so I apologize. I don't want to offend anybody, but I noticed a lot of people, and even I initially did not have a mask that fit my face properly. So this mask, perfectly good mask. It gives good protection. You put it on, always with the earpieces, and you can have a tie or whatever. I'm going to pinch here. I'm going to pull down on my chin. I'm going to set my glasses. And then am I fine? Look at the gap. This mask does not fit my face no matter what. And because it's not a tight fitting, anytime I'm in the store, in order for my glasses not to fog up, I have to change it. So I'm touching it all the time. If there's something on the outside, it's on my hands. So that's not so good for me. It might fit you guys perfectly. So then my sister found these cute masks, way cuter than that one. Cloth. It has a little place on the side that you can put a filter in. If you want to, you can order those. So put that on. Same thing with the earpieces. Okay, slide it down, slide it up. Fits my face much tighter. Still a little gap, but it's constant. There's no nasal piece here to hold this in place. I'm constantly having to pull it up, pull my glasses down, or I can't. So fits my face way better, right? You want it to fit snug here under your chin. Okay, so that's off. When I take it off, I fold it and then I throw it in the wash. So you don't want to be touching the outside if it's a washable one. And you can, most of these other ones, you can't really flip the other way without contaminating. So I just usually do the same thing and put it in the trash. So I found these. These are actually N95. So I don't need an N95 to go grocery shopping, but this one actually fits. It's called a duckbill. It's got this look. 2 in a package for $10. They're reusable. I spray the outside. I don't know if you have to, but I kind of do.
You spray it with what?
The alcohol, the spray, just any,
okay.
the 60% alcohol that you would use for cleaning your surfaces and stuff like that. Dry.
Okay.
So look at this. This is over my ears. Pinch. Got my glasses. It's automatically under my chin. It's smooth on the sides. This is the perfect mask for me, other than it's kind of hot and it's more than I need, more protection than what I need. But find something that fits your face and then make sure when you take it off, you do it this way. And then, set it aside, clean it or wash it or whatever. And then the one other thing I wanted to show you is that, so gloves are recommended.
And what is the name of the mask that you just demonstrated?
It's a disposable N95 mask. Some of the N95 masks are molded. Got it at the hardware store. $2.50. Yep. So I don't think you all need this, but find a mask that fits your face. Every face is, some are long, some are round. If you have facial hair, if you're a guy with a beard, you need something different. Each person needs something a little bit different. So when we started caring for COVID patients in the hospital, we were all fitted with the more traditional N95s, which are the molded ones. And if we didn't fit, this duckbill worked for some people that had a little bit different shaped face. And some people couldn't wear those and had to wear the more over your head things that we had very limited numbers of. And we just decided that if you're the surgeon and you can't wear an appropriate mask for a COVID positive patient, you're not doing that surgery. Someone else will take care of it for you. So you don't need that particular level of protection. Any of these others will be fine, and the washable ones are fine even without the filter. They'll protect you. What doesn't protect you as well is a plain bandana that people were saying, just tie a scarf, because it's loose and it's a single layer of fabric. This is 2 layers plus if you put a filter in for this kind of homemade mask, or people are doing that. So you should use gloves when you're cleaning your house, because if you've got contaminated surfaces, you've raised stuff, you want your hands gloved, or if you're caring for someone who's ill.
Or what?
Caring for someone who's ill.
Okay.
So certainly for COVID, but I think anybody else that's ill, it's a good idea to do that because you don't want to catch whatever they have. So you're going to put the gloves on. These are just gloves I bought in a box, right? They don't have to be any particular composition. These happen to be nitrile, and they're cool because they work with my phone. I just put them on from here. And the thing about that is I want my hands clean before I put them in. And there's a way to take them off so you don't contaminate yourself or your eyes. And they are, you grab, I don't know if you can see the sleeve.
Yep.
And I'm going to pull it off inside out.
Yeah.
And the other one, and the two go together so that they're all inside out and they go in the trash that way. So you just want to make sure that any outside surface when you're out in public where you might risk getting contaminated by somebody's fluids are out of the way. So sorry if that was I don't want to insult anybody, but it's a good reminder because I saw so many people out in public the other day. I don't go out very often, but I went to get groceries and very few of them had really good fitting masks on. Like I said, better than nothing, but not as perfect. And especially if you're trying to protect yourself from other people's secretions, even though the goal is I keep mine inside. I also don't want spew from anybody else. So a tight fitting mask or an appropriate fitting mask is good. The other thing I wanted to talk about is testing versus screening. So everywhere you go in healthcare, you should get screened. And screening is a verbal, typically plus a temperature. So when you're going into a hospital, into a clinic, whatever, not everybody is doing a temperature, but a lot are. And they're asking you if you've been around anyone who's positive, and they're also asking you about the most common symptoms. And so that's screening. Testing is actually running a test, and there's two different types of tests. One is a PCR, which is a lab test that is run, and that is the gold standard. So that's polymerase chain reaction test, PCR, and it's the gold standard. So what we're doing for planned procedures, elective procedures, is testing people up to 3 days prior, just in order to make sure we have the test results back in time. We're scheduling appointments for people to come in and get testing, and we're using the polymerase chain reaction test. Labs have to run that, and so the more we test, the slower the results. And if you live in a rural area, you may have to send your tests out, and so then you've got mail, transportation time there, not back necessarily because the results are all computerized, but it takes a while. So when we started doing cases, elective cases, surgical cases at Swedish, again, we set up a clinic to do this. And when you start testing more people than those who come in with symptoms, these are all asymptomatic, right? Then you slow down your turnaround time. Mm-hmm. So turnaround time, I was just looking at what we're seeing across the whole USA, can be anywhere from 2 hours in an in-house PCR test like the University of Washington has and Swedish has, or as long as greater than 7 days. So there are some states and counties that are reporting 10 days to get a test result back. So how can you get that information? It's really impossible. Yeah. So if you hear people saying we have enough testing, we not only do not have enough testing, but we have to test the highest risk people, either high risk to infect somebody else, like in a hospital setting, or high risk because of symptoms or age or whatever, because I know some nursing homes are doing kind of repetitive testing of folks, that those are the people that need those tests. And we have to be able to then screen people appropriately that spontaneously come in to an emergency room or a hospital for care to see not whether we're going to care for them, but what unit do they go to so that we protect the other patients that are in the hospital. So it speaks to a long ways away from being able to uniformly test everybody in the state. And when we do those tests, we ask people to actually quarantine. So not leave your house till you come in to have your surgery. So it's not just, stay in your house, but you can go get groceries. It's you prepare ahead of time and have what you need in the house and don't go anywhere till you come back.
Yeah. So we've had questions kind of lining up here. Yeah. I don't know if you're ready for them or not, but so so this is from D. Totten, who says, I read that CPAP with oxygen is generally better results than intubation.
Better results?
Better results than intubation. Maybe. So CPAP with oxygen better than a ventilator, maybe.
Well, we don't put anybody on a ventilator unless they failed a non-invasive oxygen attempt. So that may be nasal oxygen, or it may be a rebreather mask with oxygen. CPAP's a problem because it spews. So you have to be, it's not as invasive, obviously, as a ventilator, but you have to be in a different type of room. So the negative pressure room, not a lot of those around. Actually, not every hospital room is negative pressure, and there's a reason for that, because negative pressure actually, you can, no good deed goes unpunished, right? You can think, we had some nurses saying, oh, let's turn our rooms into negative pressure. And we're like, well, wait a minute, that increases your infection risk.
Mm.
So you don't necessarily want to do that. The filtration that we have in most of our ORs is not negative pressure, and it's set up the way it is because it minimizes risk of infection. So CPAP will contaminate the room that the person who's using CPAP is in. And I know some people have thought that maybe they could do that at home, and you could care for yourself at home that way, but you will be putting the whole household at risk if that's the case.
Yeah. So we do have another question from Margaret Montserrat. Is there any solid data about recovering and getting reinfected with COVID? I heard it's happening and that symptoms may be worse with reinfection.
Nobody knows. There have been concerns that that's happening, but it's not really clear that those people actually cleared the infection in the first place. And so they looked like they were getting better. And part of it has to do with how they were tested, and the fact that the antibody tests that are rapid tests. So I'm not talking about do you have antibodies, but specifically looking for the virus, have a higher rate of false negatives than the PCR test. And so that led people to believe that they were negative. And we do know that some people are sicker for a longer period of time. They get hit with some symptoms, they look like they're getting better, and then what they get is worsening. And the worsening is probably their immune system overreacting, which is why now people are looking at using steroids, for instance, dexamethasone, to suppress the overreactive immune system. So it's not clear at all that people are getting reinfected. And the antibody tests to see if you've formed an antibody are really thought to not be valid until you're probably about a month from your initial symptoms. You can, it is also not clear exactly who can transmit and who cannot. So that's another one of those things where we're seeing little bits of articles being published with incomplete information that have been a little bit, it's concerning, and you want to be alerted to those things, but have been probably misleading.
So we had a couple questions about the N95 masks. So a couple questions about N95 and KN95 being similar or equivalent, and whether or not the N95s should be reserved for healthcare workers.
Yeah, right now, the N95s are being produced in large volumes, and actually these ones came from China, the ones that I bought, which is actually where most of ours came from in the first place.
Yeah.
I am concerned about what's going to happen if we do get a second surge in Washington State, for instance. The surges we're seeing in many of the southern states that have had high volumes in the last month are those places never really totally closed down, and they're really just got started probably a little bit slower, and so their big high rates of cases are happening now rather than like ours did in March. So we haven't had a second wave anywhere yet. We're still seeing first waves showing up, and we could have a second wave easily in the fall when we start having influenza as well as COVID, and as people continue to try to get back to work and back to business. So, travel, I think the airlines are a great example. They started out with only doing, nobody in the center seat and all of that. Now they're full. The planes are full. Most of them are requiring masks. But again, not everybody's wearing their mask all the time. And so as we do more of that, when we're in close quarters, I think we are at risk for that, and we may have supply issues again. We had big supply issues in the beginning in our state, and other states are struggling with that right now.
So let's see, this is from Caroline Ziza. Aren't the infection rates increasing once again, even as we find ourselves in phase 2 in King County? It feels worrisome that we are trusting to go about life as usual and try to reopen our economy and go about our lives for essential services.
I think it's a catch-22. We can't stay totally closed together. And even Anthony Fauci said, be cautious with what you do with your reopening, but wasn't suggesting that we totally stay closed. The reason is that if you stay totally closed and we don't have a vaccine, and it's likely to be a long time before we have a vaccine. I know that's going to be a question on people's minds. And the moment you go out again in public, which you're going to have to do at some point, you're exposed. So I think we need to figure out how we function with separation, virtual conferences that we're doing, and some of the restaurants that are creating outdoor seating that never used to have it, and some of those kinds of things that we're going to have to figure out how to go about a little more normal life. And we will see some cases, and what you want to look for cases in your state, wherever you are, is as we test more, you'll see more positive cases. What you want to look at is who's being hospitalized and who is dying, because that tells us if we're being too liberal with our activities. And you look to see where those populations are coming from, like we had a resurgence in South King County in Washington State that turned out to be really essential workers. They were healthcare workers and restaurant workers that lived in, that are not well off, and that lived in multifamily units or tight quarters, and were out going to work all the time, and maybe didn't protect themselves when they went, and did something. I will tell you that what we've seen in the hospital is spread from person to person from staff, not from patients getting providers sick. And so that's why I mentioned that
how do we know that?
By contact tracing. Yeah. So we have had in a variety of hospital settings, not just in Washington State, where there have been little clusters of, say, nurses getting COVID or other staff. And we've seen this in nursing homes as well. And you look at those people and you realize that they've let their guard down maybe when they're on their breaks. They're around their friends whom they trust. And you can love your friends and trust their intellect and all of that, but we're all human, and we all make, hands-on type stuff. And we've seen people well-meaning in areas that aren't direct patient care, where they let their guard down. And I think that's one of the things you have to think about, is that these are people getting COVID that aren't on COVID units. The people who are caring for COVID patients now, because we mostly know who they are. Now, it was not the case with New York, for instance, where they had this huge explosion and nobody knew who had it, who didn't have it, and so on. But when you look to see who's exposed, and even with healthcare workers in general, the risk of getting ill as a healthcare worker is like 7 or 8%.
Okay.
And getting ill in the community is 5 or 6%. So there's very
pretty
little
equivalent. Yeah.
Very little difference. Yeah.
And then do we have any statistics? I mean, there's a bunch of questions that are queuing up, but I'm curious, do we have any statistics of what your chance of getting COVID is if you go into the hospital as a patient? Are there any
I'm
statistics
not
around that?
aware of any reported cases of a patient who came in negative who went out positive. I'm not aware of any of those.
Mm-hmm.
Some weird stuff that we don't know about, for instance, with newborns. There's a
Mm-hmm.
few situations, like we've tested so many newborn babies and they don't appear to get it just by a vaginal birth.
Mm-hmm.
But there are a few that have been positive, and the supposition there was that there was a breakdown between the maternal fetal interface prior to delivery, that the baby was exposed to the virus through the mother's blood or secretions or whatever. So there's some weird things like that, but I haven't seen reports of that working the other way. Yeah.
So here's a question from Beth Burnett. She asks, what are your thoughts about people who are exposed and then test and the test is negative? For example, the person is exposed by a friend and gets tested. The results are negative. The person is quarantined for 14 days. A week into the quarantine, the person is tested again and still negative. Does the person need to complete the 14 days of quarantine with 2 negative test results after exposure?
Well, the problem with the 14-day thing is what I think is clear is you're exposed, and the range of developing symptoms runs something like 3 days to 14 days. So I think you need to wait the 14 days, and I wouldn't test till 14 days, because we've had some asymptomatic positives. You know, they get tested, they delay their surgery, they want to get it back and get ready for it. They test a week later and it's still positive. So you run into this repetitive testing thing that's frustrating. I would wait the 2 weeks, and if you don't have any symptoms and you don't test positive in that period of time, that you're clear. And then you can go about your business, but again, being careful so that you don't get exposed someplace else. Yeah. I think a really important, this is a good time probably to mention the differences that we've seen with large group gatherings recently.
That sounds good. And I'm going to tee up another question. I got to go grab my cord, but could you also then talk about where we stand with the therapeutics, the monoclonal antibodies and clinical trials after you talk about large group gatherings?
I'm not going to say very much about that but yes,
Okay.
I can address it for sure. So the example that I wanted to share, and this, you guys all know this already, but you may not have compared the two together. So, Seattle, we've had huge numbers of protests for Black Lives Matters. We've had all kinds of people out there. We've even had healthcare systems, including my own, it's Swedish, saying we encourage providers to go and protest if they feel that that's the right thing to do, but wear a mask and, clean your hands and all that kind of stuff. You see pictures of the protesters outside walking around, not very far apart, and some are wearing masks and some are not. And we've not seen an increase in cases from that encounter with a lot of people. And yet, coming right out of Tulsa, 2 weeks after the indoor Republican convention, we have a huge number of positive cases in a city that didn't have that at all before. So indoors, hardly anybody wearing masks. There's some people that were. And it's a natural experiment, I guess you might look at, that you don't want to be indoors with a lot of people right now. And when we're going to ever get back to, meetings and gatherings of large groups, I don't know. There was, one large 100 people in a church, I don't know, it was a party or whether it was a church gathering where sadly a young woman died who had lived through cancer. And, she had parents that did some strange things for sure. And she probably didn't need to die, but she did from being exposed at this church gathering where a lot of people ended up positive. And she was very high risk with a recent history of cancer and so on. So, that's in a place tight, large numbers of people without masking and, you know, being too close, you just don't want to go there. So that speaks to being careful outdoors as being a reasonable thing. Yeah.
Yes, somebody had asked a little bit earlier if the virus can get into your eyes and what do people need to do to protect that area?
So my glasses will help me from direct stuff, but honestly, if I was really worried about it, I would want one of those shields that starts here, not the ones that just do this, but that comes down, and I would wear a mask underneath. That would be optimal protection if you're going somewhere where you're worried about that. Goggles, you can wear goggles over glasses. Goggles will seal to your face, so that alone, keeping your nose covered. You see people in the store, they go in there and they slide their mask down under their nose or you know, on their chin. They're not wearing a mask, so stay away from those guys.
Yeah.
Well, anyway,
That's actually the worst, right? Because they're
and they're like, why bother? You know, think you're, and then they'll slide it back up again, and so you know, yeah, it's a kind of a trick.
Yeah.
I think they know. I think they're not paying attention, or maybe they were forced to wear a mask in and they're being rebellious. I don't know. I've seen a few people do that, refuse access, and the moment they get in the store, they pull it down, and that's pretty obnoxious. So all you can do is stay away from them.
Yeah.
I wanted to throw out a fun fact, or not. I don't know if it's so fun. There's been talk about cats getting COVID, but maybe not dogs. But now in the world, I'm going to give you some facts that you probably don't need. The animals that have tested positive in the whole world: 1 tiger, 1 lion, 5 cats, and 5 dogs. And obviously, I don't have a pet tiger, although I have a dog. My daughter's dog kind of looks like one, but where the household animals have gotten sick is direct contact with a COVID positive patient, family member. So if you are helping somebody as an advocate who is COVID positive, you might just, like, the first thing I want to do is snuggle my dog, right? And I thought the dog couldn't get it. So you want to make sure that they know that keeping the pet away from your secretions is the right thing to do. And if you get an animal that has those symptoms, call a vet right away. So I know.
Interesting. We love our animals. So could you also comment about, is it safe to go to a regular doctor's appointment, do lab work? And also we had that earlier question about what do people need to think about for when considering elective surgery at this point?
Yep. So I will thank Michael Wood, one of our board members, who forwarded a really nice article from called Project Patient Care, and it's from Meriwether and Argus, I guess. I don't know if it's Argus or Argus. And I'm going to just read off a couple. I've embellished a couple of these, but they're like just additives, pointers that they had for going to clinic visits or lab tests or that kind of thing. So you want to know if you're going to be screened for symptoms or tested for COVID. So like I mentioned, everyone should be screened. If people are not asking you your symptoms, then don't go in that place. Turn around and say, you know, if you're not screening me verbally and or with a thermometer, then you're not screening the other person that just went in, and so you don't want to be there. The testing is really pretty much being reserved for procedures that might be invasive procedures. So if you are getting your screening colonoscopy, you will probably be tested. If you're getting your screening mammography, you will be screened. So all of those screening options that went kind of by the wayside are back in pretty much full service. They are spacing appointments. And they may ask you to wait in your car before you come in, as opposed to waiting room situation. or they'll not have more than 1 or 2 people in a large waiting room. And they'll ask you to mask if you're in that setting before you come into a room. They may ask you to stay masked if it's depending on the type of procedure that is happening. And if you are accompanying somebody else, you mostly are not able to come in. They for sure will ask you the screening questions if you're accompanying somebody for surgery. And if that person is disabled, then you should be able to come in, get them settled, and then go. And they're mostly asking people to wait in their cars. But if you have if you know that person's there for a long procedure, you should figure out a way to be contacted, with a cell phone or something like that when it's time to come pick them up, so that you're not sitting somewhere in a car all day. So those are things that you want to have happen. One of the questions is, will you need a mask and gloves? Most people are not requiring gloves, but masking is very common. We ask all of our visitors in the hospital to put a mask on. Visitor options have opened up, and where there were times in recent months in Washington State, at least, where in the King County area, where people could not come see their loved ones who are passing away. We now have the option for 2 people to come. There may be restrictions on one person only being identified as the visitor for different circumstances. So all of that stuff you want to ask about first before your loved one or your client is coming in for a surgery that may require them to stay in the hospital afterwards. And then
we are at time.
Oh my
and
God.
I know the hour just went by so quickly. So I'd like to thank Dr. Dale Reisner for being with us today to talk about COVID and Resurgence. I know that the hour went fast. There's probably more to talk about. We're appreciative of everybody who was able to join us today. We are working. Yeah, what is that?
Margaret.
Yeah. We're working on putting together another call for the 27th of July, and we will likely do 1 or 2 calls on a Monday, probably 2 weeks spread out in August. But you'll receive a survey. Let us know what you are most interested in hearing about, what topics and particular speakers. And thanks so much to supporting the Washington State Health Advocacy Association. Really appreciate it. Stay safe.
If you have an important question that didn't get answered, please make sure to, how do you want to do this, Robin? I'm happy.
Yes. Okay. So send it to info@washa.org, and we'll pass that along to Dale, and she can answer that question for you. So thanks so much. Stay safe. Mask up. Be
Wash
well.
your hands. Wear your
Wash
mask.
your hands. Take care, everybody.
Yeah. Bye.
Bye.